Hello, this is Rachel Babin from oncologynews.com.au, proud producers of the Oncology podcast. Welcome to another fantastic edition of the Oncology Journal Club. This week, Eva Segeloff talks us through the I-SPY trial, and Hans Prennan chats about personalised therapy in lung cancer. And whilst not oncology specific, the team also discussed the recent #MedBikini controversy. Craig Underhill chats with our guest interviewee this week, who is none other than Dorothy Keefe, CEO of Cancer Australia and a big fan of the show. So thank you for your time, Dorothy. We hope you enjoyed today's informative episode. As ever, links to all of the papers discussed today are available in the notes. For the latest oncology news and podcast updates, subscribe to the Oncology newsletter. You'll see a link on oncologynews.com.au. This is Rachel Babin, and this is the Oncology podcast.
Hello, everyone. Welcome to the Oncology Journal Club podcast. And this week we go back to our tried and true regular format where we bring you the latest and greatest paper analyses from what's new, what's interesting, and what's quirky. And wait till you see what I've got for you. In fact, actually, Hans, I believe you've been looking at it all week since I posted it. Welcome, Hans.
Thank you, Eva. Very glad to be here.
Welcome. Click on the link, Craig.
Well, hi, Eva. Hi, Hans. Hi, Rachel.
So this week we have some papers, as I've said. We've got a special guest interview. It's a real pleasure to have Dorothy Keefe, Head of Cancer Australia, with many wonderful insights. We've got a short interview in this episode, but there is an extended interview if you want to hear Craig saying and a lot and Dorothy giving us pearls of wisdom. So this week I'm going to present the updated results from the I-SPY2 trial consortium published in JAMA Oncology Online, July 23. The publication's entitled Association of Event-Free and Distant Recurrence-Free Survival with Individual Level Pathological Complete Response in Neoadjuvant Treatment of Stage 2 and 3 Breast Cancer, 3-year follow-up analysis for the I-SPY2 adaptively randomized clinical trial. So I-SPY2 will be familiar to all of you who treat breast cancer. But this particular sub-paper is looking at whether we can answer the question of what a pathological complete response means in terms of survival endpoints when we use neoadjuvant treatment. Now, we know that neoadjuvant chemotherapy and endocrine therapy improves the rate of breast-conserving surgery because of tumour downstaging. We know it allows us to assess the degree of response. And we have data that it does correlate with survival outcomes from pooled patient-level meta-analyses of nearly 12,000 patients from 12 different randomized trials with various regimens of standard chemotherapy. And that's called the Collaborative Trials in Neoadjuvant Breast Cancer, CT-NEO-BC. So I-SPY2 is a really interesting trial, and for those not familiar with the adaptive design, this is a perfect example. It's a randomized multi-center phase 2 platform where there's a master protocol, and it's been continuously enrolling patients since 2010 and has completed the evaluation of 15 different investigational therapies. The trial is designed to identify a large improvement in path-CR, thereby providing the rationale for larger confirmatory trials in appropriate subgroups of patients. But it's also allowed us to de-escalate therapies and to change the adjuvant therapy component in non-responders. In this trial, there are 8 different subtypes defined by hormone receptor expression, HER2 status, and genomic risk of recurrence as per the 70-gene assay known as MammaPrint. High-risk breast cancer is present in all patients with operable stage 2 or 3 primary tumours. That's larger than 2.5 centimetres. So tumours that were not high risk, for example, HER2 negative hormone receptor positive with low 70 gene assay scores were excluded. HER2 positive tumours were included and always had an anti-HER2 agent added to the standard arm. And all of the arms have standard of care chemotherapy, which is usually 12 cycles of weekly paclitaxel with trastuzumab for HER2-based low-risk cancers, adds an investigational therapy. 20% of patients in any of the subtypes are randomised to the control therapy and the others to the investigational arm. So this paper looks across all the therapies in the first 950 patients. They had 10 different investigational agents. Mean age was 49. They defined path-CR as the absence of invasive disease in the breast or nodes at the time of surgery. So YPT, they couldn't have micrometastases either. Any patient who progressed, withdrew consent or received non-protocol therapy before surgery were also adjudicated as a non-path-CR. With a median follow-up of 3.8 years, 35% of patients achieved a path-CR. That's 330 of the 950 patients. Overall, path-CR rates were higher if you got an investigational therapy than control. The 3-year event-free survival was 95% if you achieved a path-CR compared to 78% if you did not. That's a hazard ratio of 0.19 with a 95% confidence interval 0.12 to 0.31. The rates of path-CR were lowest for hormone-positive HER2-negative tumours, and they increased right up to around 68% if you were hormone negative and HER2 positive tumours. The 3-year disease relapse-free survival was 95% for those with path-CR versus 81% for those without a hazard ratio of 0.21. So overall, these results are consistent with that of the large pooled analysis. So this paper still doesn't give us the definitive answer on the value of path-CR and the exact correlation with survival outcomes and recurrence outcomes, but it certainly is very encouraging. We have a number of trials that are underway looking at changing therapy after achieving a non-path-CR that will also be important when the results are revealed in the future. There was an accompanying editorial entitled, "What Constitutes a Valid Surrogate Endpoint in Cancer Clinical Trials?" And I think this paper shows we're getting closer and closer to being able to use path-CR, and that will really assist more rapid introduction of new agents into the clinic. Craig, have you got a question?
Yeah, I do. Well done, Eva. So there still seems to be some reticence in Australia to embrace neoadjuvant treatment, but there's a move, as you know, in many tumours to look at that more and more. So do you think this adds to evidence that that's really what we should be doing?
Yes, I think the initial reluctance was that there was no correlation with outcomes. I think that breast has been quite slow to adapt this, mainly because operable tumours can be very readily removed. But in this time of COVID, in the time of restricted hospital access, I think that will push us more into neoadjuvant therapy, and that may well be a legacy of our COVID experience. There is the concern about over-treatment that remains, and we still haven't identified the optimal management, particularly for a hormone-positive HER2-negative cancer.
So, Hans, let's just ask quickly about Belgium. I had the experience of lucky enough to do a sabbatical in France 10 years ago, and I was amazed that really anyone with a palpable tumour went to neoadjuvant, and it was only the screen-detected women that predominantly had surgery up front. So that was really quite different to the practice here. Is that similar in Belgium?
In Belgium, it's quite similar, but the trend came a bit later. So it's only the last, let's say, couple of years, there's more and more trend to go to neoadjuvant therapy with chemotherapy.
So Hans, you're now going to present a paper published in Nature by one of my favourite people, Gary Middleton. Did you know that some years ago, Gary and I did a house swap? Our families swapped houses. I went to his house in Surrey and he came to our house in Australia. Now, my husband left out a huge bottle of sun cream because anyone who's seen Gary, he's the whitest of white with fair hair. And we warned him, even though the sun wasn't out in Sydney, he still needed to use it. So the first night we got there, I rang him up and I said, Gary, I'm in your bed. And he said, well, I'm in your shower. He was as red as a lobster. He didn't use the sun cream. So hopefully he's a little bit smarter when he does his research. Over to you, Hans.
Thanks, Eva. So I'm very pleased to present his paper. So I also know Gary from a few meetings, a very nice guy. So he led the largest umbrella trial in non-small cell lung cancer. It's called the National Lung Matrix Trial. Just as an introduction, you know that the majority of targeted therapies for non-small cell lung cancer, that they are directed against drivers that are more prevalent in patients with light exposure or zero exposure to tobacco smoke. So this is only 20% of all patients with lung cancer. So it means that in the 80% other ones, we have to find other options to treat those patients, and it's a very high priority. This National Lung Matrix trial is trying to do this, and how do they do this? They use NGS to match patients to appropriate targeted therapies on the basis of their tumor genotype. And they just published interim results where they screened more than 5,000 patients, and around 2,000 were eligible for entry into the trial, and actually 300 entered the trial to receive genotype matched therapy. So which method do they use? They have a 28 gene panel test, and they stratify patients after progression on standard of care therapy. In the trial, there were 22 cohorts, so with different combos, testing 8 different drugs. I will not go into detail because you have to read the paper if you want to see all the details, but they used an FGF receptor inhibitor, an mTOR inhibitor, CDK4/6 inhibitor, ALK, MEK, AKT, EGFR, and a VEGF inhibitor. Just 2 examples, patients that had a MET amplification or an exon 14 mutation or a ROS fusion, they were treated with crizotinib. If they had a PI3K mutation, they were treated with an AKT inhibitor. And also there was one cohort when you had no actionable aberration, and they could be treated with a PD-L1 inhibitor, durvalumab. So what was the conclusion of the trial? Actually, despite preclinical data supporting the drug biomarker combinations, only a limited number of combinations had clinical relevant benefits. And it was mainly in patients with lung cancers associated with minimal exposure to tobacco smoke. So the biggest problem seems that tobacco-associated non-small cell lung cancer, they have more clonal mutations compared with non-smoker. So it increases the chance that other oncogenic drivers could coexist. Often they're also more quickly resistant. And also maybe the drugs they used in this trial were not the most selective ones. So we know that, for example, for RET fusions, we have very selective drugs. And also crizotinib, it's at the moment not the best drug to target MET, etc. But as this is an ongoing trial, we will see more results in the future. So I think still a lot of work to do there in that field.
And Hans, I'm going to just mention we talked about the stunning progress achieved in lung cancer treatment over the last decade in episode 7. So that is a walk through all of the developments in lung cancer if anyone's interested in delving a little bit deeper. So just a comment on that paper too. So off study, I mean, that's pretty much where we're getting to now. People to have an NGS assessment of their tumour and then assigned to targeted therapy. The real issue is access to, 1, the next generation sequencing, and 2, getting access to the agents. But I think this is really a proof of principle study that in this tumour, this is really the way to go. We need to have biomarker directed therapy.
Now, I've got a question for you, Mr. Twitter Underhill. Have you looked at the hashtag #MedBikini?
I've been looking at it all week, and I never saw so many doctors in bikini.
So let me tell you the story because it relates to a brand new segment this week. It's called Amazing Article of the Week. And for this segment, we go outside oncology to find an incredible article, and nothing can really beat this one. Dead set. This was published in the Journal of Vascular Surgery. It was published online in December 2019, but it was really when the print version, August edition, so just printed and released recently, came out. The title of the article is The Prevalence of Unprofessional Social Media Content Amongst Young Vascular Surgeons. And the background is that the authors say in 2012, a study showed that over 40% of adults search for their potential doctor online, and they said the information they found impacted their choice of physician. So 3 authors, all men, accessed the Association of Program Directors in Vascular Surgery directory and compiled a list of graduating vascular surgical trainees from 2016 to 2018. And you may wonder how this passed the ethics committee, and that's exactly right. No ethics. So these 3 authors looked at neutral Facebook, Twitter, and Instagram accounts for all the information on these people they took off this directory. And they screened them. They spent hours and they screened them into clearly unprofessional or potentially unprofessional content. Now, clearly unprofessional content, they defined as Health Insurance Portability and Accountability Act violations, intoxicated appearance, unlawful behaviour, possession of drugs, uncensored profanity, or offensive comments about colleagues, work, or patients. Whereas potentially unprofessional content included holding or consuming alcohol, inappropriate attire, censored profanity, controversial political or religious comments, and controversial social topics. They compiled descriptive data and applied Fisher's exact test to compare the categories. They found that 68% of the accounts were held by men and 32% by female. Don't forget, these are vascular surgical trainees. And not surprisingly, over half of these people could be publicly identified from the information given in this paper. They concluded that young surgeons should be aware of the permanent public exposure of unprofessional content that can be accessed by peers, patients, and current or future employees after showing that 26% of accounts had either one of the 2 types of posts, clearly unprofessional or potentially unprofessional. Now, this caused a huge backlash with the comments that this targeted women and highlighted sexism within the medical field, because most of the controversial posts involve women wearing bikinis. So very quickly, the hashtag #MedBikini started trending, and bless them, many women started posting themselves in their bikini. One said, "I wear swimwear to the beach in my free time, and I still can be a competent and compassionate physician at work." The best one, however, was a female doctor in Hawaii who was actually swimming at the beach when a surfer got hit by a boat and started bleeding profusely from his leg. And this is the post of Dr. Candy Survival Dr. Bikini. "I will save your life in the middle of the ocean when you get hit by a boat. I will take you out of the ocean on a surfboard turned into a backboard. Tie off your exsanguinating wound with my rash guard. Take you to my primitive urgent care. Stabilize you in an hour with IV, oxygen, morphine, fluids, Foley, and put your open femur fracture in a Bucks traction fly you to helicopter to a third world hospital, order and interpret all the labs, x-rays, CT scans, suture and staple all your wounds, splint your clavicle, humerus and scapular fractures, sedate you, put in a chest tube in your fifth rib fracture, pneumothorax, and fly you by jet to a first world country, all in my, you guessed it, bikini. You have to go on and look at this. It is dead set for real. So what happened? One of the authors jumped on Twitter and apologised, saying, "We are sorry we made young surgeons feel targeted and that we were judgmental." And they recognised the inherent gender bias with men assessing the appropriateness of women's clothing. They also apologised for using a national database without permission. The journal made a statement saying that due to the outpouring of what was called constructive commentary, the article was retracted. However, I still found it on Google Scholar just the other day. Now, Hans, I know you've been very busy proposing a follow-up study.
Actually, I was quite surprised. And I must say, I also post a lot of pictures on social media, also of my private time. But I think doctors are also just regular people. So I think everybody should be allowed to do that.
And Craig, we could post the picture of Dr. Jeremy Shapiro in a mankini.
Oh, let's not do that, please, Eva. We'll have no followers on social media if we do that. But it's a very funny hashtag, #MedBikini, because there's some great responses from women. I love the one, there's a doctor and she's a breast cancer survivor, and she stands with her back to a camera and she's looking at the painting of the screen. I think it's in the Met in New York, with her top open, boobs obviously looking at the painting and the painting of the screen. So there's some really funny things. So have a look, people. Not for too long though, Hans, please.
As a journal editor, I just can't believe this got through the editorial board and the reviewers. So it is funny, but it's also a little bit sad, and we really need to do better. However, please join us in posting yourselves in a bikini or a swimsuit, male or female, #MedBikini, #Oncology Journal Club Podcast. Let's see if we can get anyone to do that. And now this week's interview. Your challenge, Craig, is to get your wonderful guest to post on #MedBikini.
Well, it's an absolute pleasure to welcome Dorothy Keefe onto the Oncology podcast. Thank you, Dorothy, for coming on the program. We're going to talk a little bit about optimal care pathways and review a paper, and then we'll have a little bit of a discussion about some other issues. Never waste an opportunity. We're seeing we have Dorothy on the show. So Dorothy is a clinical professor at the University of Adelaide, and she's a recent CEO of Cancer Australia. So thank you very much, Dorothy.
Thank you very much for having me, Craig. I'm delighted. I think this is probably my favourite way of doing Journal Club.
Fantastic. Very 2020, as it turns out.
Indeed.
So tonight we're going to be looking at a paper by Rachel Bergin entitled Concordance Between Optimal Care Pathways and Colorectal Cancer, Identifying Opportunities to Improve Quality and Reduce Disparities, published in June in the Journal of Evaluation in Clinical Practice. So Dorothy, would you like to outline this paper for us, remembering people can click on the link to get more information, and then your thoughts about it?
I think, although this is a descriptive paper, I think it's very useful because it's beginning the journey of showing whether optimal care pathways are actually working in Australia. And I think the idea was, this is a survey that was done before the optimal care pathway was actually introduced, looking at whether people were complying with the sorts of care that the optimal care pathway would encourage. So, as you know, optimal care pathways are designed for the clinicians and the patients so that everybody knows what should be done in the best management of a particular tumour. And there are now many of these optimal care pathways for many of the common cancers, some of the rarer cancers, and also the extra one that is looking at the whole journey from an Aboriginal and Torres Strait Islander perspective. And what it enables you to do is question whether we in Australia are able, and possibly willing to abide by the guidance in this pathway. And it was clear from looking at what happened before the colorectal one was introduced that it was very patchy. There were certain things that people were just not doing and certain things that people were quite willing to do. I mean, for example, GPs didn't seem very excited about doing a digital rectal examination on a patient that might have colorectal cancer. So it gives us a very good baseline, and it enables us then to hold the system to account about the best care and whether we are able to deliver that best care. So it's actually a good tool for the patients to say, you know, this is the sort of care I should be having, a joined up patient pathway from early diagnosis right through to survivorship or palliative care. And it also gives the clinical staff the ability to say to their health service administrators, well, we need to be giving this sort of care and we're unable to, so we would like you to fix that. And then, of course, there have been other papers that have come out since that have shown that if you do align the care with the pathway, you have better outcomes. So there is a paper that I'll have to send you the link for that shows if you follow the colorectal cancer pathway, you have better outcomes. So I think this is all just really good ways of enhancing the delivery of care, and comes back to the fact that we know that if we just do the things that we already know we need to do, we'll have better outcomes.
So this paper was basically, as you say, some baseline data. Was a cross-sectional survey done between 2012 and 2014. So it'd be interesting to see if that's now changed over time. But one of the things I picked up with my regional hat on was it was interesting that patients from rural areas were significantly less likely to receive a colonoscopy within 4 weeks compared to urban.
Yes, and they were more likely to have more GP interventions before they got referred for diagnostic care. So it does show that it's likely that some of the variation that's occurring across the country is not good for patients, and that's what we're trying to reduce. We're always trying to reduce the unnecessary variation. And we know that in many cancers, the outcomes for rural and remote patients are less good than they are for metropolitan patients.
So I presume the other paper you referred to is the Luke to Marvelde paper, alignment with indices of a care pathway associated with improved survival.
That's the one.
That's another paper we've considered reviewing on this show. So we will put that link up for people to look at. So it is interesting. So they have some evidence that if the more closely aligned you are to the pathway, the better the outcome. So that's probably one of the first demonstrations of perhaps the merit of these OCPs.
That's exactly right. But the piece that misses is whether introducing them has increased the alignment. So if you can show that there was poor alignment before they were introduced, that if you're aligned, you have better outcomes, then you need to also show that the uptake is increasing. And that is something that we haven't yet been able to demonstrate, although there have been pilot programs in all states aimed at implementing the optimal care pathways.
So one of the issues for me in working with the OCPs is the difficulties about real-time data and collecting the data, analysing the data in a timely way and giving feedback to clinicians. So what do you think we can do to resolve that issue?
Craig, that's a really big issue in Australia, and it's patchy between the states. So there are some states that can have data within 3 or 4 months of a patient undergoing a procedure or having a diagnosis, and there are states where it might be 2 years. Now, that's clearly not acceptable. And I think most of the cancer workforce has been advocating for quite a long time for real-time data. And I think we have to use this COVID-19 pandemic crisis, just to segue into that, in order to drive more timely data. I think it's absolutely clear that we should have the data in real time. And it is not impossible. The Dutch, for example, were already showing in March that there had been a reduction in cancer diagnoses due to the coronavirus pandemic. We could at that point estimate that there would be reductions in cancer diagnosis, but we couldn't tell you how big they were. And we can't give you a national figure about that yet. So I think that this is an area where we need to be advocating with the data collection bodies, the cancer registries, the AIHW, in order to get those data in a more timely manner.
Yeah, we've had recent experience with the Cancer Council in Victoria where it takes them about 18 months to clean the data for how many patients were put on a clinical trial in Victoria in a year. So, that kind of time delay is really so last century.
Indeed. I think that New South Wales, Queensland and to a certain extent WA are ahead of the curve within Australia. I think, on the plus side, we do know that we have some of the best outcomes in the world for cancer. We know that from longevity, and we know that from the data that we do get, albeit a bit late. And there are some other countries that have fabulous data but don't have our fabulous outcomes. So I think what we're striving for is having both, because you can't reduce unnecessary variation if you can't demonstrate to people that it exists.
Yeah, and to me, it's addressing those pockets of disparity, bringing them up to the average would be where we need to invest to really make the next step in improvement in survival outcomes in Australia, which segues into, I guess, the next question. You mentioned the optimal care pathway in the Aboriginal and Torres Strait Island population, which was published 2019, I think, for the first time. So how do you think that's going to fit into the landscape and the likely impacts of that?
Well, I think this is a really important piece of work because, as you know, it's all very well having the best outcomes for cancer in the world as long as everybody has them. And in Australia, the gap in cancer outcomes is actually widening, not getting narrower. And it's widening in two ways. It's widening because we're improving the outcomes for non-Indigenous people, and Indigenous people are getting more cancer and it's at a later stage, and so they're doing worse. So having an OCP that focuses on enabling Indigenous people to achieve the good outcomes that everyone else achieves is absolutely vital. I see it as, the most important thing that we can do is to improve outcomes for Indigenous people with cancer. And that involves changing the way the whole health system interacts with and communicates with our Indigenous peoples, because we know what we need to do, but we're failing to actually be able to deliver it. So yes, I think this is extremely important. And in fact, Cancer Australia has developed an implementation guide and toolkit for the optimal care pathway that I think might have just sneaked onto our website recently as a soft launch, but that we will be launching more formally later in the year, that has lots of tools available to help health services to actually use this OCP optimally.
My eldest daughter, is a second-year university student studying social work, and she lectures me now on social determinants of health. And so in this space, I think, it's not just what we do in cancer, is it? It's really all about that socioeconomic disparity, the voice to Parliament, and all of those issues that we need to address.
Look, I think you're absolutely right. The social determinants of health are a really big problem. And I think the intergenerational impact of the social determinants of health is important. And I've been looking at, if fixing the social determinants of health is not easy, but the question is whether it's sufficient to close the gap or whether there's something else there that we haven't looked at or haven't considered. I came across the term social epigenomics recently.
Wow.
It's a fascinating topic. It's looking at the epigenomic and epigenetic changes that occurred when Europeans arrived in Australia in the Indigenous population. And we can do all we like, but if there are ongoing epigenomic and epigenetic changes, we need to work out a way to undo those, to change them back. And I don't know how we do that yet, but I think this is an area that we need to look at. The other thing that we need to do is look at what we're calling disadvantage-driven policy setting. So just for an example, another piece of work that we're doing is we're looking at a roadmap for pancreatic cancer over the next 5 years, because the outcome for pancreatic cancer in Australia is appalling. At the moment, it's so bad that there's no gap between Indigenous and non-Indigenous outcomes. So I imagine, and I don't think I'm just imagining it, I think the evidence would suggest that if we improve the outcomes of people with pancreatic cancer by making the journey better, doing all the things we already know to do, joining up all the gaps. We will create a gap between Indigenous and non-Indigenous outcomes that doesn't currently exist. And we can't do that in 2020. What we have to do is we have to say, how do we raise survival rates in pancreatic cancer for everybody?
Yep.
I haven't got an answer yet, but it's the way we need to be thinking.
So thank you so much again, Dorothy. We look forward to you coming again on the show in the future.
Thanks very much, Craig. It's been an absolute pleasure. And of course, always happy to come and talk about some of the exciting things happening.
Thank you.
Absolutely fascinating. And Dorothy Keefe is such a wonderful guest, has so many interesting insights. So please listen to the extended interview with Craig, available on the Oncology podcast website.
So it's a really interesting interview, Eva, where she covers a lot of topics, and some of which we've already talked about a little bit on the previous episodes of the podcast and recent episodes. So certainly worth a listen.
And she's a podcast fan, isn't she?
She is. She sent a message. So before she gave agreement to go on the show, she actually listened to the episode and she loved the concept, thinks it's very 2020, and loved some of the earlier episodes that she listened to. So that was good news.
And I bet you she loves quick bites.
So the quick bites, people can click on the link if they need more information. The first one is a question: is pregnancy safe after breast cancer in patients with the germline BRCA mutation? And the answer is yes. So we can reassure patients there's no risk. And the second one is a diagnostic biopsy-adapted immunoscore, predicts response to neoadjuvant treatment and selects patients with rectal cancer eligible for a watch and wait strategy. So this is a European group, both in France, Romania, and also South American sites as well, that looked at the question of, can we predict those patients that are safe to follow a watch and wait strategy after chemoradiotherapy for rectal cancer? So an interesting paper, a very provocative new paradigm that's certainly not standard of care yet, but worthy of further investigation. And the third one is more for our preclinical science nerd followers: resistance to PD-1 blockade in the absence of a metalloprotease-mediated LAG3 shedding. So the point of looking at this one was really just there's emerging interest in why some patients respond to checkpoint inhibitors and others don't, and what are the mechanisms of resistance. So this was a paper looking at the role of LAG3, and there are some studies around with combination checkpoint inhibitors and LAG3 inhibitors. So this is some of the preclinical explanation for that. So I think there's going to be lots and lots and lots of trials in this space going forward, with the opportunities to improve in the already good outcomes in the immunotherapy space.
You just wanted to show off.
About what? About my knowledge of LAG3? No, not at all.
Are you still with us, Hans?
Yes, I am. Speaking of lag, it's time for PBS Update.
No wonder Craig likes doing it. But you get me this week. So from the 1st of August 2020, we've got 2 drugs for rare cancers, but which will greatly benefit our patients. So the first is for entrectinib for patients with metastatic non-small cell lung cancer with a ROS1 gene rearrangement. And the second is lorlatinib for anaplastic lymphoma kinase positive non-small cell lung cancer. That's ALK positive non-small cell lung cancer in patients who have progressed following other treatment options. And that's your PBS update. Well, I love these original format podcasts because you never know what is coming up. But sadly, it's time to end. I'm off to take a photo in my bikini. No, not really. That would be scary. I'm going to say goodbye. Bye from me.
Bye, Eva.
And bye from me.
And thanks, Ray.
Thank you.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.